Okay, we're going to go ahead and get started back after lunch here with our panel. Hello, hopefully you had a good lunch. So we're going to go ahead and get started back. We're just a few minutes late, but we should be okay here. There we go. Okay, so I am very excited to moderate the panel discussion that we have. This is the interventions across the Intercepts, the best practices in Iowa. So again, my name's Lori Hancock-Muck. I am the statewide behavioral health manager, a position that I've been serving since the first part of January. It's a new position here in Iowa. In that position, it's really kind of helping support the courts in being able to really identify and get services for those individuals who are justice involved, who have mental health and substance use disorder services, kind of in a nutshell. With that job, though, prior to being there, I was over at HHS for 10 years doing regulatory work, compliance. So for me, jumping over into the judicial branch has been quite a learning curve for myself. So understanding the systems, the different services that are around, and for court services. From the other side over at HHS, I was pretty well versed in substance use disorder treatment services. I feel like that's pretty been my niche for the last 30 years. So I could talk all day long about the ASAM criteria, some of you know that, and talking about compliance and regulatory for licensed substance use disorder treatment programs. So jumping over here, having to learn everything. And what was really cool was what I started to do was reach out to people that were doing these services that weren't those traditional clinical licensed treatment services. So met everybody up here, and they were gracious enough to kind of sit down and talk with me. Even like Lynn, I was able to observe one of the clients who was having a hearing with assisted outpatient treatment in Johnson County. So it's been just really eye-opening. I'm excited about what they're doing. They're really changing lives. They're very innovative, and it's diversion. And Dr. Hess talked about sequential intercept modeling, which we're going to go through tomorrow. Michelle O'Brien from National Center for State Courts is here. Her and I are going to do a presentation in the morning and then really spend a lot of the later morning working in these groups in our districts and talking about what we've learned today, how we can put that back into our communities. There's some things that are maybe sustainable, doable, that we can take back, at least have those conversations. So the thing I would like for you to think about when we go through this panel discussion today is things that we can take back to tomorrow morning when we have our action planning activity. So where do you see the biggest gaps in your districts? That's what I want you to kind of think about, where the barriers are at, and also where the strengths are too, what resources you do have. Who the leaders and those champions are in your districts. Who do you need to have at the table? Who are those influential people? I see Leslie, and I always think of Leslie as being one of those people. Who do you want on your side to kind of help guide that conversation, to really have those conveyors, to have them come to the table to make those changes? And then lastly, again, thinking about each of the panel discussions that we have today and hearing more about their programs and what they have in Iowa, thinking about what you can take tomorrow when we do our action planning about these are the things that we would like to bring to our communities. These are the things that are missing. Are they doable? So we can have those kind of more richer conversations about it. Okay, so with that, I'm going to go ahead and introduce them really quick. I got them in a different order here than where they're sitting. So Courtney Stenzel, she is the coordinator for the 7th Judicial District Mental Health Court Program. She's been with Transitions Mental Health Services for over 21 years and brings more than 18 years of specialized experience working with mental health courts. Courtney has over a decade of program development experience, including leading efforts within a residential program and playing a key role in launching the Scott County Mental Health Court in 2016. The program has then expanded to 4 additional counties in 2021. Who do I got next? Okay, Shelly. Shelly Gehrke serves as the site director at the Polk County Life Services Building. In addition to her leadership role there, she also oversees operations at the St. Vincent de Paul Sobering Center, which officially opened on November 18th, 2024. With 2 decades of experience in the nonprofit sector, Shelly brings a wealth of knowledge and dedication to her work. She holds a bachelor's degree in healthcare administration and an associate degree in certified medical assistant. And Margaret, you're next. Jessica, I can't see Jessica there. Okay, Officer Winter has been a member of the Urbandale Police Department since 2005, earning her bachelor's degree in criminal justice from Simpson College. Jessica started her career with the Urbandale Police Department working patrol from 2005 to 2013. In September of 2013, Jessica transferred to the Criminal Investigative Division, where she became a detective. And then in January of 2023, Jessica transferred to the Support Services Division, where she's the officer for the back in 2023, the newly created Crisis Intervention Team. And Maragret Lano serves as the mental health co-responder, so those two are a team with the Urbandale Police Department Crisis Intervention Team. She has a Bachelor's of Science in Psychology from Iowa State and specialized certifications in crisis intervention, advanced de-escalation, and critical incident stress management. She also serves as a judicial mental health advocate for Polk County in the past and is passionate about improving the mental health commitment process outlined in Iowa Code 229. And we've got Kim. Kim's the Director of Clinical Services at Community Support Advocates, where she provides leadership and oversight of clinical programming to include the OCR, the Outpatient Competency Restoration Program. She's worked in the mental health field for over 20 years, serving in both therapeutic and administrative roles. Kim's earned her Master's of Social Work degree from the University of Iowa. And then we have Melissa DuVall. She's the team lead for Community Support Advocates. And she's also in the Outpatient Competency Restoration Program that you're going to learn about. This is a role she's held since the program's inception. In this position, she oversees the services designed to support individuals involved in the judicial system in restoring competency and engaging in their treatment. And last but not least, we've got Lynn. Lynn's lived in Johnson County since 1985 and has practiced as an attorney since 2004. She was appointed as a Johnson County magistrate in 2012 and worked as a judge until 2018. Lynn now works as an assistant Johnson County attorney in the civil division. So welcome them. So we're just going to start, and I'm going to just moderate by having some general questions for them, for all of them to answer, and then I've got a couple specific questions for them, and then hopefully we'll have time to be able to open it up. And again, feel free to use the online questions as well, too. Okay, so just to start, Courtney, we'll start with you, obviously. Could you just kind of briefly describe your program to everybody, and then we'll kind of have you go through the line of people.
Well, I definitely picked the wrong end of the table to sit at. So, again, my name's Courtney Stenzel. I'm the coordinator for the 7th Judicial District Mental Health Court Program. I was supposed to be joined by our fantastic judge, Patrick McLeay, but unfortunately he had to leave town unexpectedly for a funeral. So he wanted me to apologize for him not being here, and this was something he was really looking forward to. So I'm flying solo today. So we have a mental health court program. We just started our 9th year. Started as the Scott County Mental Health Court Program, and then the pandemic hit and the world shut down. And one of the good things that came out of it was we learned that utilizing technology can be really beneficial. So through the pandemic, we started communicating with all of our clients via Zoom and different meetings like that, using the telephone a lot more instead of everything having to be in person, and realized that, okay, we can make this work. So we were able to expand from Scott County to Cedar, Jackson, Clinton, and Muscatine. So those are the 5 counties that we currently cover. The purpose of a mental health court program is to assist those struggling with mental health issues and substance abuse that have found themselves in the criminal justice system, that we feel if we can get them connected to what I call the 3 S's, support, structure, and stability, we can stop the revolving door and get them the treatment and services they need so they can be in recovery, living healthy, productive lives in our society. We do that through a 4-phase program. So all of our clients start in phase 1, and the way I describe it, it's kind of like building a house. Phase 1 is literally the foundation. Do you have a doctor? Who is your psychiatrist? Who is your primary healthcare provider? Do you have a safe, supportive place to live? Do you have access to medication? Do you have a toothbrush? Do you have shampoo? All of those very basic needs. As they work through the phases, we go to phase 2, and at that point, we're kind of starting to put up the walls and coming up with a plan for that individual. Mental health court's very individualized to each person, so everybody's plans look very different. But during that step, it's, okay, we've got all these appointments and we've been taking you to them, but now, how are you gonna get there? So let's learn how to ride the bus. Let's learn how we can utilize our insurance to call and set up transportation. Building that, the foundation's been built and kind of putting up those walls. By phase 3, we're really working on goal setting. So what are our goals? Do you want to work? Do you want to volunteer? Do you want to go to school? What's your life going to look like? So many of our clients, when I ask them the question during the screening, what do you do for fun? What are your hobbies? What are your interests? They don't have any. They don't know. So helping them identify what is your toolbox going to look like? What are those things that you can do? Applying for jobs, getting involved in employment services. If we're not working and we're on disability, that's okay. We can volunteer. We have to have productive things to do with our time. By the time they get into phase 4, we want them living in the house, and we just want stability. That might be 6 months, it might be a year, but we just want stability. We want to make sure that they've continued to build on all of those different levels, but by the time that they graduate our program, they're living healthy lives in our community, they're involved, they have natural support systems, and we do that all obviously through supervision of the judicial system. So I could talk about mental health court forever, but we have a lot more people who would like to talk, so I think I will go ahead and pass.
Hello everyone, my name is Shelly and I serve as the site director at St. Vincent de Paul Sobering Center. We are located at 1914 Carpenter Avenue in the Polk County Life Service Center building. I have been there since July of last year, so I kind of was hired when this was already a thought process, was already put into place. So how we operate is we are open 24 hours, 365 days, 7 days a week. When the city shut down because of weather, by golly, we stayed open. We provide a safe place for individuals, male and female, ages 18 and older, to sober up. Our team consists of an amazing group of EMTs, paramedics, registered nurses, and a community navigator. It's important to know that we are not a detox center. We do not have any medications for them at all. Our basic one that we do have is Narcan, and we have used that one time. We are not their residents, so we have to gently remind them, we are glad to see you, but you can't be living here. And we are not a shelter. Our center features a single room. We have 10 chairs that do recline. We are told they're not very comfy. We need to get new ones. However, you are there not to to be comfortable, but just comfortable enough to sober up. While they are there, we do offer them blanket, crackers, granola bar, and water if they like. We also can offer them anything from clothing, shoes, or a shower if needed. Our service is free. We do not ask for any insurance. We don't ask for any form of co-payments or any form of payment at all. To meet our guidelines, you do have to be obviously over the age of 18, so we've kind of changed our protocol since we have opened up. So between the ages of 18 and 20, they do have to have a blood alcohol content, and we do test for that. So even if they register at 0.02, they can go ahead and they can come on in. Anyone ages 21 years or older, they have to have a BAC of 0.08 or higher. We also accept those that are self-reporting substance. We have absolutely no way of testing it, so it is an honor system that they say, hey, I've used, and then we're like, okay, you've met our guidelines. Our guests can stay up to 23 hours. However, if they are publicly intoxicated, once they're underneath that threshold, they do have to leave. And I am the mean one, and it's at 2 o'clock in the morning. You're under the legal limit, you do have to go. A lot of our others are kind of soft and like, oh, it's still dark out, you need to stay. And I'm like, no, we can't be doing that. We have to keep them knowing that we are not here as a shelter. Our average stay is approximately 9 hours, and during their stay with us, they do meet with a community navigator who offers up resources and some options that they can do. Whether they take it or not, that's totally up to them, but at least they have information in hand, and we also do not case manage. One thing I did forget to tell you is that if they do come in and they leave, they cannot come back in for 12 hours. However, they can come back by police department or mobile crisis. I have a lot more to talk about, but we'll pass the mic.
All right, I'm Jessica Winter, and as stated in introductions, this is my partner, Maragret, Lano, and we are the crisis intervention team with the Urbandale Police Department. We also serve the city of Windsor Heights as well. We are a co-responder program, so Margaret and I go to calls for service in real time together. We get dispatched out to our dispatch center, just like police officers do for any other type of call for service, and we respond to the scene when we're available. We dress like you see us up here, so we're pretty plain clothes approach, so we got rid of the uniform and do the softer approach to respond to calls. When we're not there, follow up. Oh yeah, when we're not there. We've trained all of our officers. All of our officers in our department, thankfully, are trained in CIT. They will fill out a referral form. So if they go to call for service that has a mental health or substance use component, they will fill out a referral form and send it to us so that we can follow up with it the next day. So that's been a huge component as well. That keeps us successful in our first year or two of the program. We realized that we had just as many calls for service as we were getting referrals. So that told us right away that this was a 24-hour program that needed to be implemented, and hopefully someday we'll get there.
Hello, everyone. Again, I am Melissa DuVall. This is Kim Hagen. We are with Community Support Advocates. I am specifically the team lead for the Outpatient Competency Restoration Program, or OCR, because that's a lot of words. So to describe OCR briefly, it's essentially what it says it is, right? We provide competency restoration services to individuals in their community, right? So as opposed to going to an inpatient facility, we are available to participants who are eligible for like pretrial release. And we exist because there was some change to the legislation, Iowa Code 812, a few years back, to allow for this type of treatment to exist in the community as opposed to a facility setting.
To add to that, Iowa Code used to say only identify inpatient competency restoration, and that was the change that occurred. There was a recognition that there needed to be some treatment on the outpatient scene as well. So the goal was to lighten the load on the inpatient hospitals that were taking on a lot of clients. And a lot of times clients were waiting in jail way longer than they needed to be because they could not get into the hospital. And so the outpatient competency restoration program was developed. So we've been operating since 2024. We're still a relatively new program. We're learning every day and trying to model some of the same things that are occurring within the inpatient program to keep individuals in their community.
Hello, everyone. My name is Lynn Rose. I work as an assistant Johnson County attorney in Iowa City, Iowa. And I've had the privilege to be involved with the work to establish a civil mental health court. So this is a specialty court in the parlance of the judiciary. And unlike the 7th Judicial District, my cohort down here at the end of the table, that's a criminal court. So those folks will be on probation, and there's a whole set of tools available. The participants in our court are all subject to an Iowa Code Chapter 229 involuntary commitment. And that's how the court has jurisdiction. And it is a specialty court or a treatment court. Our clients all have diagnoses of serious mental illness. The model that we use is called assisted outpatient treatment. And it's a fancy way to say we talk to people. And as our participants come to us, we do check-ins, we call them. They would be an informal sort of status hearing. And we work with participants to identify the goals that they might have. The goal for the court generally is to help people get off of commitment, to end their mental health commitment, and to identify maybe some things that are important to them to do in their lives, rather than kind of be stuck in the cycle of going to jail and the emergency room and being hospitalized for extended periods of time. Eligibility requirements for the court, you have to be an adult resident of Johnson County, subject to a Chapter 229 commitment, and have a diagnosis of serious mental illness, and that needs to be the primary diagnosis. We do have people with co-occurring SUD diagnoses, but that cannot be the primary diagnosis. And additionally, if you recall Dr. Hess's remarks about what constitutes a serious medical problem under that Estelle case, all of those were serious medical problems, but they don't all respond the same way to the AOT motivational interviewing model. So the behavioral personality disorders or primary diagnosis SUD, we've had several folks and they've borne out what the science has told us. The model doesn't work very well for those folks. It works very well for schizophrenia, bipolar disorder, depression, generalized anxiety disorder. Right now, every single one of our active participants has schizophrenia diagnosis as their primary diagnosis, not because we just picked them that way, there's just that many folks. So that's where we're at. We started seeing people in 2023. We are funded previously through the region, currently through the district. We have a mental health referee who is assigned to our court, and our team is 4 people, our mental health referee, our coordinator and peer support specialist, who are employees of the Abbey Mental Health Center, and then myself, and I'm obviously a county employee. But because our coordinator person is not a court employee, it's important to have someone who can submit motions and proposed orders for certain things, stuff like that.
Lynn, can you also talk a little bit about what Carrie as a coordinator, what she does and what her role is, and also with the peer support, what kind of services that she's able to offer?
Yes, so people will sometimes say, well, what is the purpose of this court if all you're doing is sitting around and talking to people? So the first purpose is to engage with the participants. We've had several of them say to us over time, no one's ever asked me what my goals are before. Are you serious? And we'll go, yes. What are your goals? You know? And so our coordinator organizes the docket for us, even though she's not a court employee. We don't meet at the courthouse. We meet in our conference room at our access center in Johnson County, which helps kind of lower the stress level for our participants. And then the coordinator reaches out, our coordinator for the program reaches out to the various service providers that serve our clients or our participants. And our participants, the plan for every one of them is different because they're individuals. They have different goals and different needs. And so our coordinator gathers information from the various service providers and puts that together and then does a report, and that's what we use when we discuss the case with our participant. We say, all right, here's what we've understood, how things have been going the last 2 weeks. What do you have to tell us? You know, how's it going? And we do that. The peer support specialist is a person who is available on the ground every day to interact with folks. And our peer support specialist is the person who will transport them to hospital appointments or take them grocery shopping or do some of those kinds of things that really help our participants move successfully through the community, particularly folks who have transitioned out of a long hospital stay or are really institutionalized and are trying to move back into the community. They just need a little extra support to do some of those things, and that's where our peer support specialist fits in. Also, they kind of work as good cop, bad cop sometimes. The peer support specialist will sit and listen and talk to the person and listen to information, but our coordinator will say, listen, I've got this report that's coming in and telling me you actually haven't been taking your medication for the last 5 days. What can you tell me about that? Let's discuss that. And that's an important thing. The court function then, when they come in for the status reports, is a monitoring function, and lots of people, when they talk to us, will say, oh, well, you're just making sure they take their medicine, right? Yeah, we talk to them about taking their medicine, but it's also about monitoring the service providers and what's happening. And that's been an eye-opening and interesting experience, right? We have one person who, that participant just has made incredible progress, working really hard, taking all kinds of responsibility for their own health care and taking care of themselves. And the court mandated report due every 90 days on this person, when we went back and looked, the last 3 reports had been cut and pasted. Only the date had been changed. Well, we had all kinds of collateral information that indicated that this was inaccurate. How do you inform the person who's vested with making medical decisions that this report isn't okay? And in fact, our participant was afraid to have us inform the medical provider because our participant was afraid that they would be accused of being resistant or recalcitrant. And so that's just one example. But the monitoring goes both ways. It isn't just about eyes on the person monitoring how they're doing all the time. It's also helping them understand they may be entitled to services they've never been able to access because it's actually difficult to navigate the system. We can help you navigate the system a little bit, but you're entitled to this. Or, okay, now you've been with us for 6 months, you're doing great. You need to figure out how to ride the bus. Do you want some help with that? Because we won't always be here to give you a ride in the car. Some of those kinds of things. It's just been a really interesting experience to move through that with people. And our peer support specialist is the person who gives them the bus map and then rides the bus with them.
And I'm going to give you another question, too, and kind of put you on the spot. So you mentioned motivational interviewing, and one of those questions makes me think of, so how are you able to balance individual rights with treatment compliance in AOT?
That's a fascinating question. So participants who come to the program have been court-ordered to participate in the program. The process that exists under Chapter 229 vindicates due process rights by providing the opportunity for a hearing, and that still exists. So if a person is ordered to participate in the AOT treatment court and thinks that they shouldn't be there, they can ask for a hearing in front of a judge that is not the AOT court judge and have a hearing, and then they have to do whatever that judge orders. But in terms of folks who are actually in the program and participating, one of our learning experiences and one of the things that's been very interesting is you can order somebody into a program, but you can't order them to engage and participate, right? And so individuals have to make a choice. And so the only thing that we have, what I would call compelled people to do, is come to the initial meeting after they've been ordered in, where we have a discussion to just explain to them what the structure of this court program is and how it looks, and what they could expect of the team and what we would expect of them as participants. And it's been in those meetings where we've had people say to us, no one's ever asked me what my goals are. Are you serious? And yeah, we are. And so they get to decide if they're going to engage. And we do have a few people in the program that our label is monitor only, where they've been ordered in, but they won't engage. They won't come. Like, they'll refuse to get in the car to come to a status hearing. We're a civil court. There is no authority to send somebody to jail for refusing to do something. No one's on probation. So we do not engage or use those kinds of tools, and I think the best research tells us that doesn't work for treating brain illness anyway. It just isn't an effective kind of tool. And so we ask people to engage with us. And if they don't, then we do the monitor-only status. And the monitor-only status is, are you making appointments? We'll reach out to those folks and remind them that they have an appointment. Do you need a ride? That kind of thing. We've had 3 or 4 people who started as monitor-only, and then the peer support specialist picks them up from an appointment, and they ask, can I meet the other people on this team? Will you help me do these things? So we find that people decide they want to come play. And I guess that's how we balance rights. We talk to them and we treat them like a human, but we understand that they are subject to a court order. Their due process rights have been vindicated, and it's not voluntary to participate in the program.
Okay, thank you. I'll take you off the hook now, and you can pass it to Kim and Melissa. Okay, so for the competency restoration part, the question I have for you guys is, what strategies do you use to help individuals regain competency outside of an institution?
First, I'm going to clarify what competency means. I'm a mental health professional. I'm not a judicial person, and some of you out there might be mental health professionals too. So we are also a court-ordered program, and we are for individuals who have been deemed incompetent by a psychologist or a psychiatrist. And essentially that means that someone within the judicial process has determined that they just don't think that they're able to participate within their charges and understand and appreciate and assist in their own defense. And so they have to go through an evaluation, and if that psychologist or psychiatrist determines that they are incompetent, then essentially everything just halts. So their charges, they're not able to go through the process, they're not able to have their hearing and face their charges. So what was happening previously was there was only an inpatient program, and so people would sit in jail until they could go into one of these inpatient hospitalizations in order to be restored to competency. And so we are an outpatient program where individuals who do not have violent charges are able to be on the outpatient side of things, be in their community, get the services that they need. As Dr. Hess was talking about, a lot of times it's medication, it's therapy. We can then work with them on these things and then work with them to restore them to competency so that they can move through the judicial system. So for those of you that didn't know what competency was, because I didn't before I started in this program, so there it is.
Yeah, I took the word brief really literal. My apologies if I wasn't clear. So as far as strategies that we use to assist individuals in becoming restored to competency on an outpatient basis, I kind of liken our program to kind of 2 programs in one, right? So we have the education side that's really heavy on informing about what their charges mean, and whether they factually and rationally understand that, individuals in the courtroom, their roles, how to work effectively with your attorney, some of those like interpersonal skills, not interrupting, So we have that piece, right, which falls under the didactic education piece. And then we have kind of the mental health piece, where we will connect individuals with services that will assist their, what Iowa Code 812 refers to as a mental disorder, so that they can become competent. So that looks like medication management, therapy, maybe referral to other services and assistance with certain substance abuse treatment as well. Yeah, lots of referrals. We can assist with things like Medicaid applications, getting that stuff figured out for them, or with them rather. So essentially the strategies that we use are those two pieces of the program kind of together, but we are very client specific in nature, right? So if somebody happens to have a lot of services already engaged, we won't focus so heavily on connecting them because they already have the resources that they need. Or if somebody doesn't really need the education piece because they understand the court system, they just need more assistance with their mental health, we kind of just go client specific, what their circumstances require in order to get them restored. So yeah, that's what we do in the outpatient world.
And can you guys talk about how you coordinate services with whether it's the courts or the treatment providers in order for them to be successful through the competency restoration program?
Yeah. So we have guidelines within Chapter 812 that tell us that we have to report to the courts on certain time periods. So that's how we are coordinating with them. As you were saying, that we can't make people do things within our program. They are court ordered, but we can't make them take medication. And so our job is to report to the court they're not taking medication. And then the court gets to determine what they do with that information. We do have some communication with attorneys at times, and recently we have started serving juvenile clients, and so we've had a lot of communication with juvenile court officers, which has been amazing. If any of you are out there, thank you. You guys are doing a great job. So that's how we're able to communicate with them. It is difficult sometimes. Though it is court ordered, we still have to obtain releases of information for all of the providers. So our clients do have to sign those releases, and we have had instances in which clients will refuse and they don't want us to coordinate with their medication provider or their therapist. And so there are some gaps there that have proven to be some barriers when we're not able to have access to that information.
Okay, I'll have you move it over to Margaret and Officer Winter. So with the crisis intervention team, can you guys talk about how does the CIT model change the way law enforcement responds to behavioral health crises?
So one of the biggest ways it's changed how we respond to behavioral health crises is that our officers are responding with a lot more empathy. They're looking more towards the person than they are towards the problem. So when they arrive on scene, they're a lot more, looking towards de-escalation strategies versus does this person need to go to jail? So they're taking a lot more time, a lot more empathy, talking a lot calmer to really de-escalate the situation and to figure out where the root of the problem lies, right? It's not focused on the problem, it's focused on the people, like how did we get here? And it's changed our approach a lot. Our use of force instructors have to fill out a report every year. And in the last 2.5 years that we've been doing our program, we've seen a decrease in use of force. And I didn't ask them to, but they went ahead and gave a shout out to the CIT team and the CIT program for the reason that our use of forces have gone down. So huge success to measure that way.
Okay. And can you share an example of a situation where CIT made a difference for both the individual and the officers?
Yeah, so there's one call in particular that I always think of when we talk about this, and especially when we talk about our soft approach and what me and Jessica wear every day to work. So there was a young kiddo, probably 10 or 11, I think, if I remember right, out in the front lawn, pretty escalated, an autism diagnosis, oppositional defiant, kind of that like hot mess laundry list of like when people are having behavioral concerns that you always hear. So he was out front, pretty escalated. I think his Lego set got broke that day. I don't know. Got taken away. Legos got taken away. And so he's very upset out on the front lawn. Parents were having a hard time getting him de-escalated. And as me and Jessica are driving there, we're reading through trip history, and the last couple times patrol had been out with them. They ended up having to go hands-on with him, which is always unfortunate. We don't want our officers to have to do that, and we don't want kiddos to have to go through that. But to keep him safe and his family safe, that had to happen. So me and Jessica arrive on scene, and there's 2 female patrol officers, so in their fancy get-up with all of their fun doodads, and they call it tactical. They look really cool. So they're standing across from him, and he's got this huge log in his hands. And we walk up, and as soon as we walk up, he's like, I want to talk to those 2. And it's me and Jessica. And the two female officers were like, okay, cool, we're gonna step back, and immediately just a change in demeanor for him. He obviously, there's some traumatization that happens with having negative interactions with law enforcement, so he associated that uniform with danger, stress, this is gonna turn out bad. So just me and Jessica showing up in a more relaxed way was able to help him get de-escalated. He thankfully put the giant log down, which ended up being hollow and not that heavy, so scared us a little bit. Able to get him calmed down. Parents brought out PRN meds, so that also helped de-escalate him. We ended up tucking him in with his Legos to take a nap and talk to parents about more resources. So that was a great outcome for the family. But then we always like to do a little debrief with our officers, and they too said, you know, when you guys showed up on scene, we totally saw a change in his demeanor. He immediately calmed down, and one of the officers was like, I really thought that I was gonna have to tase that kid, and I did not wanna have to do that. Like, that is the last thing I wanna do at work. So thank you guys for being there, because I didn't wanna have to go through that. I didn't wanna have to go hands-on with that kid, and I'm so thankful that you and Jessica were there as that resource to help de-escalate the situation. So, twofold. Both sides.
And that call too, it wasn't one that we were automatically dispatched to. So we have a criteria set through our dispatch system that if a call meets a certain type, a label, if you will, like a domestic or a welfare check or whatever, we have like 7 types of calls that will be automatically dispatched to as the primary unit if we are in service. And this wasn't one of those calls. I think it came out as a domestic, and we're not primarily sent to those. So because our officers are trained in CIT and they're aware of what we do and what we bring to the scene, they actually requested us to come here to help de-escalate the situation with this child, and it ended up way more successfully than, as she described, the previous 2 where they had to go hands-on with him and restrain him because he was just so escalated. So.
And I'm guessing that's one of many stories, you know, when you describe it, how you're dressed and your appearance, and just being able to kind of change that whole scenario for that individual who doesn't feel so fearful, and seeing that kind of authority, what they would think of, you know, in the uniform. And you kind of think of that black robe effect, and you kind of have that opposite one where you're more approachable, and they're going to be probably a little bit more willing to kind of de-escalate because of your skill set. So, okay. We can pass it over to Shelly with the Sobering Center. So tell us about the Sobering Center's reduce on strain to the emergency rooms in the jails.
All right, this is what we're really, really proud of. So we have been open since November 18th of last year. So as of the end of August, we have served 1,026 guests. They have come to us by police departments, Polk County Sheriff's Office, EMS, Mobile Crisis, Friends and Family, and self-referrals. So how we are seeing a reduce in stress in those emergency departments is we're actually working with the emergency department, so they will do like a triage, and they'll make sure that there's nothing else wrong with them, and if they are just intoxicated or if they have a substance, then they can come up. They usually give us a heads up, hey, just to let you know, we're sending you so-and-so up by taxi, and that way then we can go ahead and we know what we are expecting. With our police departments, we are working with within Polk County, so anybody who has their law enforcement or emergency services within Polk County can only utilize Polk County. So like anybody outside of Polk County cannot be bringing people into the Sobering Center. So we do work with Sergeant Lorna Garcia from the Des Moines Police Department. She definitely works with her team, letting them know, hey, bring everybody in instead of taking them to Polk County Jail or taking them to the emergency rooms. So just a quick little highlight here. Of those guests that I mentioned, which was 1,026, 516 have been brought to us by law enforcement or by mobile crisis. So we have actually saved for the emergency department, so an average of just going into the emergency room is about $1,500. We have saved Polk County emergency departments $2.5 million by them coming to us. I'm going to keep going on my numbers here real quick. We have saved law enforcement over 15,000 hours by bringing them to us. So how we work that out is that instead of them going out to the Polk County Jail, and then they have to go out there, and then they have to fill out their paperwork, and then they get in their car, and they have to fill out paperwork, and then they come back. All they have to do is bring somebody into us. We will make sure that they meet our guidelines. We just need your badge number, and they're out the door. They don't have any paperwork at all. We do all the paperwork, so that way they can get back out on the street faster. And we actually have saved $77,400 for booking fees and daily fees at the Polk County Jail. Thank you.
So I'm going to throw you a curveball too. So off the record.
Lovely.
So, well, I had a side conversation with you a while back about the state fair coming up, and I'd heard some conversations that, the Sobering Center would be an amazing alternative to all of the arrests and holdings that they do for, East Side Night. So I was wondering, did that ever pan through? Did you see an increase during the state fair?
Oh, we did not. So we actually have saw a decrease in numbers through the warmer months. We have been told by a lot of our regular guests that when it's warmer out, they would rather be camping, staying underneath bridges, or in camps. So we figured in the next couple of months, our numbers will be going up just because they'll be out more active out and about, and then they will come to us.
And then what type of services and supports do you provide individuals with once they're ready to leave the Sobering Center? How do you coordinate those services?
Sure. So we do have a community navigator. There's actually two. So there's one that works overnights, and then we do have one that is there Monday through Friday from 9:30 until 6:30 p.m. And what we do is we start engaging with them right away. If they are sober enough or they are able to tolerate us asking a bunch of questions. So what we want to make sure, we want to make their needs met. It may be something simple of, I just need to go get my driver's license, I need something, I need clothes. Or is it that, I'm done, I can't do this anymore, I need to go into detox. So then our community navigators, they start working right away. I'm trying to get this information, trying to get the process going. So that way, when they walk out the door, they do have information in hand, or if we're able to, we can take them to detox right away.
I'll have you pass it to Courtney. So for the mental health court, what makes mental health court different from traditional court processes?
It's very different. Our mental health court program is multidisciplinary, highly collaborative, and trauma-informed. So all of our team members, we have a judge, myself as the coordinator, mental health professionals, we have probation, county attorney, and public defender. And also very consistent. So we don't like to have turnover. Best practice says keep those people in those positions as long as possible. So the consistency with our team is pretty strong. So when our clients are coming in, they're seeing the same judge, they're seeing the same staff members every week. But we also make sure that all of our staff have training and trauma-informed. It's important that we're able to recognize how trauma impacts the clients that we work with. So I think somebody had mentioned something about the black robe effect. Judge McLeay never has his robe on. I think he probably prefers it that way anyway. But making sure that if we do have to have a bailiff come in, that they're not just standing there the whole time as our participants are coming into court, just kind of being aware of that. And then also through the evidence-based practice treatment that we utilize. If you've never observed a mental health court, I highly, highly recommend it. Our program is always available if somebody'd like to zoom in, which is a very nice feature that we offer, and just kind of observe how it is. It's much different than any normal courtroom. Our clients are very comfortable. They don't come up, they don't stand at the judge's. They don't stand up in front of the judge. They sit next to, it might be me, it might be the assistant county attorney that they sit next to. It's just a very warm, welcoming environment. Sit where you're comfortable, and judge usually leads it with like, how's your week been? Tell me about it. How are things going? And just having that person-to-person conversation. The other thing that Judge McLeay is fantastic about is he ends every conversation with each participant. Is there anything we can do for you? What do you need from us? And our clients, I think when they first start in the program, they're like, this is a loaded question. But as they stay with us through the program, which on average is about 1.5 years, we have some clients that are in our program 3 years because it takes them that long. It's very individualized. But average length of time in our program is about 1.5 years. So by the time they get to know us, we've built that trust with them, and they know that they can come in and say, like, hey, I thought about drinking last night, or I did drink last night and I need help. The number one thing about our program that we tell all of our clients, and this was from Judge Mark Smith, who helped us start the program. He's now retired and we miss him greatly. He was fantastic. But vigorous honesty. We can help you with anything if you're honest with us. But if you come in and you're lying or you're not telling us about something, we can't help you. So our clients know that the more honest they are with us, the more that we can help. So it's just a very different environment than a normal traditional courtroom.
And you kind of answered this already, but is there anything more you wanted to say about how you support the participants in addressing both the legal and the clinical aspects during the program?
Yeah, I think that obviously we address the legal piece of it. They're coming to court. As they move through the different phases, they come less frequently. So when a client starts in mental health court in phase 1, they're coming every week to court. So we're pretty up to speed on what's going on. But it's really nice to be able to help the individuals. Like, we've got a gentleman right now that we're working on getting out of jail. We're taking him into our program. And we just found out that he has warrants in other counties. So we, as a mental health court team, are already on it. Judge McLeay has already sent emails to the county attorney in that county. We're making arrangements. So we're able to address legal issues, I feel like, much quicker than the normal court process, or if it wasn't as intensive as our program, and get things done quicker. Also, our public defender who represents our clients is fantastic, Dana Copel. She's contracted through the public defender's office. And if she's able to help the clients with things, she does. Otherwise, she can let them know that's not in my realm of expertise. We have our clients come to us asking, like, hey, I need help with this, or I've got issues with child support, what do I do? So it's just nice that our clients have all of us available to them every single week. So that's how we address the legal piece of it. And then in regards to just the other piece, we address anything, anything and everything. I'm not obligated as the coordinator to have to bill Iowa Medicaid for my services or anything like that. So if a client needs something, I just do it. I'm the person that's teaching them how to ride the bus if they don't have connections to services and case managers. We see so many times our clients come out of jail. And I've actually already learned a lot being at this conference today, and I have lots of questions for people, but our clients get out of jail, they have no Medicaid, the agencies won't provide services because their Medicaid's not activated, so I step in and do whatever I can to assist them in getting their Medicaid back on, getting them appointments for the community mental health providers, getting them involved in substance abuse treatment. And sometimes that takes a while. If it were just a really quick process, I think our communities would be in much better positions than they are now. But those of us who sometimes are kind of doing that ground level work, it does not happen overnight. So we're able to just jump in and do that stuff. If they need a toothbrush, I'm dropping it off. If they need really assistance with anything, we're able to help. And I feel like if it weren't for the mental health court program, a lot of those clients would fall through the cracks.
And it seems like one of those opportunities to be able to coordinate with other agencies. So I think of like PCA and the navigators, and maybe utilizing them when you are kind of at this dead end and don't know what to do. Maybe they have some resources, and two heads are better than one, kind of put that together.
I'm very excited about that.
Yeah, and also with the subject matter experts, those positions, the consultants. So there's like a justice-involved consultant coming. They're all over the crisis, children's services. Yeah, there's the whole spectrum of them. So yeah,
that's very exciting. I think too that we're doing the best we can with what we have where we're at, but to see some collaboration on a state level, I think is going to be really fantastic. We don't have all the resources that we need in our 5 counties. So to be able to refer clients to other programs in other counties and get some of that cross collaboration going on is really, I think, going to be essential and only help all of us doing our jobs that we're trying to do.
Okay. And what constitutes success for clients in the treatment court?
Success looks different for everybody. Ultimately, the general goal would be to assist individuals in getting out of the jails, staying out of the jails, getting involved in treatment, back on their medication, keeping recidivism rates down. But really, success is very different for everybody. We have clients that haven't had any contact with their children have been removed from the home, whatever that may look like, who have worked through our program and been able to get those kids back in their lives, and to see those families reunite has been amazing. Having clients who have never held down a job, get a job and maintain that job for periods. I mean, we had one client who was living in his car when he came to us. Occasionally, mom and dad would let him stay in the basement, but they set very healthy boundaries with him. And he stayed with us in mental health court for 2 years, and he got a job at the Arsenal in Davenport, Iowa, and he worked as janitorial there through a contract. And because of that, he was able to get off Iowa Medicaid. He was able to get insurance through his employer. Hospital visits, emergency department visits decreased significantly. He was just utilizing that as, well, I need help, so I'll just go there. Whereas having us available to him, he was able to call us or shoot me a text. I do take calls and texts pretty much 24/7, and our clients know that they can reach out. So, if he shoots me a text at 7 o'clock and I can give him a quick call and we can work through something, instead of him just running to the emergency department like so many of our clients are used to, it significantly helps. So I think I answered.
Great. Okay, now I've got kind of general questions, so whoever would want to answer that. And Shelly, you've kind of already answered this one, but it's about outcomes. So if you want to add more to it, certainly feel free to. But I also want to hear from the rest of you in your programs of what data you're collecting to show these outcomes. And Lynn, I'm especially interested in yours because I've seen them and it's just outstanding. So.
Well, I'm going to steal the mic real fast before I pass it down. So I attended the All Rise conference. It was my first time attending that conference this year, and it was fantastic. And one of the biggest things that I came away with, I've really been wanting to look into the outcomes part of mental health, well, just of any services, and best practices. And we found, I sat in on a session, and we found the most amazing data tracking system that was free, like, for real free. I was like, yeah, right, it's free. No, it was. All I had to do was go through like a 45-minute training, and it is this beautiful Excel masterpiece that tracks everything. So I've started utilizing it for all of our clients. We had our own tracking system. It was nothing like this, though, and it really is amazing. So right now we're tracking, obviously, basic demographics, but the amount of time from a referral to when we screen that client to when they're accepted into mental health court, all their phases, UA testing, hospital stays. There's probably like 15 different tabs of data that we're able to collect now. And I know that Iowa is working on getting a system for mental health courts specifically to utilize. So when that comes up, it's going to be really great because we'll have all that information. The hardest part right now is going back for the past 8 years and trying to get all of that into the system. So we really have a great overview of everything for the history of our program.
There are a couple things I would like to add real quick before I talk about data. So the Sobering Center has been thought of for quite a while. It has been probably over 5 years, and then this is Polk County Supervisor Angela Conley's. This is her vision that she saw this, and she actually made it happen. So she saw that there was a need to get the strain off of the emergency departments and to the Polk County jails for public intox and for substance use. Our population that we serve, it is a very high homeless or houseless population. I do call it houseless because a home is anything that you make of it. A house is a physical structure. So 98% are houseless. We see more males than females. And our youngest one was just last week. He was 18 years old, homeless, and he was a high school student. And our oldest one has been 74 years old. But the data that we collect is just the main basic data. We report that to Polk County and to the city of Des Moines because they help fund us. And then we also do 30-day, 60-day, 90-day follow-ups. That's what the Community Navigator does, and that's how we also report to those two. However, we're kind of unsuccessful on that part because a lot of people, they lose their phone has been disconnected, they don't have email, they do not have access to their email or a laptop or a computer, or they can't go into libraries because they've been banned, or they just all of a sudden say, I don't need your help anymore, or they don't want to answer the phone when we call.
So a lot of the data we've been tracking for the last couple years has been more so to justify the program on the police side of things, to let me into the building, I guess, and to convince them that this is a good service and an important service in our community. So we track a lot call volume versus daytime versus nighttime. I know Jessica previously talked about how this is a 24-hour need. We see just as many calls that me and Jessica go on during our workday as referrals we get. So that means Monday through Friday, 10 to 6 when we're there is the same Saturday through Sunday, 24 hours through the nighttime. So that's one big thing we track. We also, probably like a year and a half ago, started looking at jail diversions versus jail deflections. So I actually watched this lovely little online webinar about sequential intercept mapping from another state after a corresponder conference. And they talked about the definition between jail diversion, which we have a lot of programs here where you make it to the jail, you've been booked, and you go through those programs. But what about the deflections, where an officer shows up on scene, sometimes it's me and Jessica, sometimes it's our patrol, and says, hey, this person, there might be a criminal element, but we're gonna, use our discretion and ignore that for today and say this is your, get out of jail free pass today, and we're gonna get you services instead. So we've done a big emphasis on tracking that as well, because that is the value in our program, is just taking that whole booking process out of it, reducing court costs and things like that. So, and we also have looked at how much time we save patrol officers during the daytime when me and Jessica are there. The beauty is we are not trip responsible to like your car accidents and your domestics and your all the other things that comes with being a police officer. We just focus on those mental health and substance use calls. So we can take all day on one, and we've sat on a call for an entire shift trying to convince someone to go get help. And that's where it comes in with reducing use of forces as well. In the past, that officer is stressed. They got to get to their traffic log today. They got to go do their school checks. They got to get back to, this domestic call that's holding or a phone call request that's holding. Me and Jessica don't have that. So we can take as much time, and we are quite stubborn. So we will take as much time to convince you that, yep, today it's going to be a good day to go try to get some help. So that's another big thing we're tracking. But this year, or I guess this spring, we were very lucky, and Urbandale decided to put our program into the city budget. And Windsor Heights also put some money into their city budget. So now that we have proved our worth, I feel a little bit, and they're putting their money where their mouth is and keeping the program, we're going to look more at outcomes. That's one of my goals, is to look more at how do we define success for our community members as well. So, yeah.
So as far as tracking for the OCR program goes, obviously we track some of the general demographic data. High priority for us to track also is whether someone has been restored to competence, is unrestorable within a reasonable amount of time, because 812 says we have 18 months to get them restored or not. We also do track whether they end up requiring a higher level of care, right? So if they've come to us in an outpatient setting, but for whatever reason, what we have outpatient isn't enough for them. So they might be kind of referred then through us in some capacity, because we write those reports every 30 and 60 days on their progress in the program to the judge, the court. And we'll let them know, like, hey, this individual may or may not be attending sessions. They really need assistance with substance use, but they are unwilling or unable to stop using, et cetera, where they might go then, might then be ordered to Gehrke or an IMCC inpatient facility for restoration. So primarily it's those three that we are tracking. I do track some other kind of anecdotal information as we're just kind of starting. We've been around for about 1.5 years right now. So as long as we keep on growing, I will keep on paying attention and trying to see what other information might be useful for us to track, obviously to ensure that we're providing clients with the best possible resources and to ensure that the program is working as effectively as it can.
A couple of comments before I mention data. Y'all are going to get to do sequential intercept mapping, and I would say the civil mental health court should be, I guess if we're reading, somewhere to the left of intercept 0, right? We're trying to encounter folks before they are so deeply involved in the justice system. We do have folks with criminal justice issues who participate in our court, but if you're thinking about where does that go on the intercept map, it's, you know, ahead of intercept 0, it's -1. And that's an important thing to keep in mind, because of course it's behaviors that usually get the attention of law enforcement and people struggle with for our population that we serve. The other thing I want to just note, I don't know if there's a place on the agenda where this gets discussed. We are still learning in our program, it is new, but a piece of that learning that is so important is working with individuals who experience serious mental illness, mental health crises, that sort of stuff, is time intensive and resource intensive. Every service provider in this room will know this is true. And I'm so pleased that we have decided as a state that this is important to fund right now. But my message to our legislators and to HHS is if we find some success in the first 24 months, please do not lower the funding, because it's still going to cost money and time to work with folks and help them navigate the system. If you have an illness that makes it hard for you to pick up the phone and make a phone call and call a huge faceless institution and make an appointment, you're not going to get better if all the support walks away. So please don't think that we don't need to keep funding this if we find some success, please. All right, data. So data. Things that we are trying to keep track of and what we do. So we started actually being able to see participants in 2023. And when a participant comes in, we gather what information we can looking back 12 months before they participate. Then we track our statistics while they're participating, and then we try to keep track of things that we are able to for 12 months after discharge. And the kinds of, we use assistance from a group called the Treatment Advocacy Center, or TAC for short. They are very helpful for civil mental health courts. And we have implemented a number of tracking suggestions that they have made. So we keep track of housing status for our participants. We keep track of emergency room visits, hospital stays, days in the hospital, days in jail, arrests. Leslie, what else did we put on that? Oh yes, the accessing the crisis, either crisis stabilization unit or the access center for crisis purposes, and then law enforcement touches, I guess I would call it. You know, not just are you arrested, but have you been the subject of a call to law enforcement? And for us, the hands down, the biggest change that we have seen for people is emergency room visits and days in the hospital and length of hospital stay. And what we have found is not only does that drop precipitously, but it becomes, for our successful discharges, for going out a year afterward, it remains very low, even lower than while they're in the program. And what's important to know about that, and why it's so important not to stop funding is because those savings redound to the hospital. They do not redound to the service providers or the people working with individuals who need this level of help and the level of services and care that they need to be able to access. And that is why funding is so important. Yes, it is saving money not being at the hospital, but if you work in a public system or a bureaucracy, there's different pots of money. And if you're saving money in one pot, you're spending it somewhere else. And so part of the learning is, even though we have good outcomes because folks aren't going to the hospital, folks still need the community service worker who works with them, and they still need to be on Medicaid to afford the level of medication that they have, because they're never going to be able to sustain a full-time job with health insurance, et cetera, et cetera, et cetera.
Okay, we have about 10 more minutes left, so I want to make sure if there are questions then. Okay, so I'm going to come out to the audience and get the mics out to you guys, but while I'm doing that, because I'm a slow runner, if you guys could just, like, in 30 seconds, if those of the audience are thinking, you know, this is exciting, I kind of want to figure out how can we put these into our communities or our districts, what would be your advice in terms of the barriers, the challenges, the things that the lessons learned? I mean, if you can wrap that up in 30 seconds, but Courtney, you want to start?
I would say collaboration, lots of collaboration. We could not have a successful mental health court program without the community partners that we work with in every day, in and out. So we as a team have worked very, very hard to build those relationships. I have a contact at Vera French, I have a contact here, I can call them directly. Hey, we've got a client, we need to get them in for services. When's the next available date? So collaboration, I think, is the most important part. We all know that we have lanes and we need to stay in our lane, but at the same time, there's times where I have to step in and help probation. Probation has to help treatment. So you have to be flexible as well, and you have to be willing to help out, because we all know it takes a village.
Community partners is going to be really huge. A lot of our community partners that we use at the Sobering Center are out in the atrium. And we also have a new community partner, which is the Des Moines International Airport, who have sent two to us because they were too intoxicated to connect with their flight. But for a Sobering Center, every county in Iowa needs to have a sobering center. I kid you not. It is an amazing place. It is a place where somebody can go and sober up with dignity in a judge-free space, and there's a compassion there. And realistically, you don't need to see that person on the Polk County Jail website and go, seriously, they're there. They could have came to us. And it's also a pathway to stability for them. We give them the resources, like I said before, whether they want to take them or not, that's up to them, but every county in the state of Iowa needs to have a sobering center.
We'll share it.
Okay, you go first.
All right. I would say number one is funding. If you're going to get a CIT program, you need money to do it, to pay the people that are going to work and do the job. So grants are a great way to get started with that, and then keeping your data and proving it to your cities and what you do and how important it is the way to keep it. The other one, I will reiterate what both of them said, is the community resources. I look around this room and I can see multiple community resources that we would not be nearly as successful as if we didn't utilize them. So knowing what's available in your community already and knowing how to get a hold of those people and get people there is very important.
Ditto. No. Yes, collaboration. And I will say, like, one thing that made a huge difference for me and Jessica is Polk County Behavioral Health and Disability Services, when we started up, did these law enforcement behavioral health collaborative meetings. They were every other month. Those were huge. That's how I made so many friends in this room, is meeting all of them and getting them all into the same room. We focused a lot about warm handoffs and what was going wrong when law enforcement was bringing behavioral health patients to the hospital. hospital, and it was nice to be able to get in a room and talk about exact examples of what went wrong and how can we improve these procedures together. And now we have a whole list of phone numbers of charge nurses for all the hospitals in the area and who to call when things go wrong, and what number can I call when I have an officer in the middle of the night saying, like, this hospital won't take the person I need them to take, and so then I can call their boss or whatever. So those stopped July 1 because Polk BHCS is now the DAP5. So if Iowa PCA wants to bring those back, they're awesome. And you guys should consider doing it in all of your communities because it has been a huge, huge help. And it gets all of the right people to the table. And it doesn't just have to be law enforcement, behavioral health. It can be all of you lovely people and all of your other types of jobs. So
I think for us, it's just letting everyone in the state of Iowa judicial system know that we exist, that we are a program, and how to access our services. We are statewide, and we started in Polk County, and we are expanding. And as I said before, we're serving juveniles now, which is really exciting for us. So we're looking to expand that program even further. So it's education, it's letting people know how to write a court order, how to work with us and get our services in place.
I'll cheat and I'll say ditto because she spoke for both of us.
All of these people are correct. The two things I would add is convene your stakeholders. Convene them regularly, meet with them, keep them informed, develop buy-in, and be persistent. Be persistent. COVID interrupted us in the middle of trying to set things up. Thank goodness for Zoom. Be persistent.
I'm Kelly Yagey, and I'm the former mental health advocate for Polk, Jasper, Marion counties, and I'm actually the mother of incompetence. I'm the one who submitted the proposal to do the outpatient competency restoration to the Iowa State Association of Counties, and it became their #1 priority. One thing it didn't need was a change for the outpatient restoration. That was actually allowable, but I want to thank community support advocates because there wasn't a provider in the state who was willing to do that program. So thank you very much. Thank you. The other issue with that, my proposal to ISAC was twofold because there's still a huge gap here. The second part of that proposal is that we need facility-based restoration for individuals who have the more violent crimes, for legislators, Republican caucus staff, Democrats if you're here, I don't care. But in 2014, there was a United States Supreme Court ruling, True Blood versus the state of Washington. The issue is the state of Washington did not complete the incompetency evaluations within 14 days. And then if they were found not competent, they also got in trouble for not having that person in treatment within 7 days from the finding of not competent. The state of Washington spent over $2 billion since 2014, and they still repeatedly get fined by the Department of Justice for not following through with what the Supreme Court told them was law because it was unconstitutional to treat individuals with mental illness with such delays. I've had people who've been arrested for trespassing. They're released 9 months later on a trespass charge because at their initial appearance, the attorney knew that the person couldn't understand the charges or appreciate them, so they go back to jail where they sit for 6 to 9 months, usually my 22-year experience with this, and they sit in jail with no treatment, no services until they go to Gehrke or they go to the Iowa Medical and Classification Center for restoration. This is just horrible what we do to individuals with mental illness, especially when they're involved in the criminal justice system. And how much per person annually is the cost of that program?
We have been funded annually to the tune of $170,000, and that pays for our judge, our coordinator, our peer support specialist. The coordinator and peer support specialist are full-time, and all the programming. It doesn't pay for me, and we've served 34 people. So do the math, like Judge Christensen said, I guess. But as $170,000 a year for the whole thing.
Okay, we have time for one more question.
It's more of a statement. As the social worker in Dubuque, I can tell you, I have 3 people in my jail right now waiting for a competency evaluation. IMCC is so backed up, they're the only ones that will do it for us, that our judges will allow. We have one guy that has been in our jail for a year. This is his 2nd time being in our jail. The first time, again, on a competency hold, found non-competent, non-restorable, he was released. Again, came back in for harassment charges, being held, waiting for competency. Now he can be restored. So now we're waiting for him to go back to be restored. He's been waiting for a year.
Excellent point, because we're releasing individuals who are not competent, not restorable to the streets without any services. And I'm sure the general public would just love to know that.
And unfortunately, the law says we can't hold him.
I know.
This is where I get stuck, being social work and law enforcement involved. I get stuck because I don't think they should go out, but I don't have resources. I live in Dubuque. There is nothing. Come on. You guys, all of you probably have serviced our Dubuquers at one point in time, because we don't have anything in Dubuque. So we have to send them out to you guys. So we went that way. So we don't have anything. So then we send them off to our Mercy and our psych department. They then assess them, say, they're fine. They kick them out the door.
So, I mean, this is a great conversation, and I think this is something that can tie over into tomorrow so that we have those small group conversations about these kind of conversations, to these hard, difficult ones. So, yeah. I just want to appreciate you guys so much for being here and for taking the questions. And yeah, absolutely. I mean, I would like a standing ovation because of the work you guys do. You're so compassionate. And the work you do every day is changing lives. So I appreciate all of you guys. Thanks. And we're not going to take a break. We're going to go straight into the next speaker, Leslie's. You have that, Lauren?